Past year, we have had tremendous challenges in the administration. Although the budget was just, simple, no problems to get through, multiple legislative sessions, as you know, has been really truly challenging. The Medicaid expansion has been one of the things that will probably be the most rewarding thing that I'm able to oversee during my career, because as a practicing doctor, I saw the women who would come in and put off their care for a year because they weren't able to afford a pap smear. And I saw the musicians who did not get the mammogram because they had to save up and didn't have coverage because they had a pre-existing condition. And I've seen the children who were in their 20s who couldn't get health care through their parents prior to Obamacare, and what a difference that law has made, and particularly what a difference it's made in our state. So the numbers that you gave were great numbers, but those are 6-month numbers. So now we've had over 100,000 individuals who have been able to get a primary preventive care visit, over 430,000 who have been covered, and more importantly, they're getting services. And as a practicing doc, I think not just about the number of people with a Medicaid card, but what did that Medicaid card, what impact did that have on the ability of that individual to get care? And so those are the most important numbers. And often when you hear detractors of Obamacare or detractors of Medicaid, they'll say, well, what does it matter? Because no doctor will see that patient, right? Have you heard that before? That's simply not accurate, because what we did was we looked at that to say, okay, fine, we have coverage, but what are those numbers? And we've shared, last time I was here, we talked about the dashboard, and you can see in every parish of the state how many people have had primary and preventive services, but also they're getting specialty care. We have over 8,000 people. As you know, we're in the midst of an opioid epidemic. We have over 8,000 people who have gotten substance abuse treatment, either in a residential facility or outpatient. These are people that would not have had access to substance abuse treatment before. Lives saved. We've had over 10,000 people get a colon cancer screen, over 3,000 of whom had a pre-cancer, over 3,000 lives saved. We've had over 15,000 women get a breast cancer screen, 154 get a diagnosis, 154 lives saved. Hypertension, diabetes, substance use, mental health, you name it, we have had great success, and it's made a difference for the lives of hundreds of thousands of families in this state. So a couple of other updates. Last time you were here, you asked me about the settlement over Medicaid in terms of the partnerships and some of the initial lease payments and CMS's disallowance of those payments, but we are glad to say that we were able to negotiate from what was almost $190 million settlement last week to a $5.4 million settlement, which was a huge win for the department. Because as you know, $190 million would have been a huge burden for the taxpayers of this state. So let's talk a little bit about the federal landscape. So I talked about the healthcare statistics of this state, the lives saved, but you're also aware that the Medicaid expansion has brought in a tremendous influx of federal dollars, approximately $2 billion additional dollars per year, and this year alone we saved over $300 million state general fund dollars because of the enhanced federal match, the managed care premium tax, the hospital assessment, and other improvements in terms of the federal investment in the Medicaid program in Louisiana. We were able to save tremendous money, but also add a lot of federal funds to the state. And I would argue we are one of the poorest states in the nation. We are second in the number of children who are born into poverty, have had tremendous issues in terms of oil and gas prices going down and economic downturns that have affected our state more than any state in this nation, arguably. And so those federal dollars have helped make a significant impact. We've also hired over 1,000 people who have jobs because of the Medicaid expansion. Our managed care companies, our hospitals, our federally qualified health centers have seen job creation, and that's made a big difference. So if BICRA passes, that would end the Medicaid expansion. So right now where we are, the minimum federal investment goes down to 90% of the overall cost. Once it gets lower than 90%, it goes down to 85 or 80. Louisiana is no longer able to afford the Medicaid expansion, and we would need to reject people off of the Medicaid rolls. And unfortunately, what we've done in this country is that we've created a patchwork of care where we have care for pregnant women, care for children, care for some elderly, and adults are largely left out, and then we wait until adults have colon cancer, advanced stage disease to treat it. And that's resulted in this nation having the highest healthcare cost in the nation, in the world, almost double what it is in the country of Germany or the nation of Britain. So it's an incredibly expensive system that's not working. And so what we've seen in Louisiana with these numbers on preventive care is that we are turning the tide, and that does lower healthcare costs over time. So we would have a significant impact on coverage and would have to, by this point, we think by the time the law would go into effect, we'd have about 500,000 people in the Medicaid expansion. And as you know, the BICRA does not fix the fundamental flaws of the exchange market. The exchange markets have significant issues in terms of not having enough young, healthy individuals enroll, and it removes the individual mandate and removes some of the economic protections that make it easier for young people to buy coverage. So it would really have a significant impact on both the exchange market, which in our state is around 150,000. By that point, will be about 150,000 people, and then to 500,000 people. So it'll be over 600,000 people in our state who would probably lose their insurance coverage. It would also cause, as I mentioned, we've had a $2 billion per year increase in federal funds, so that would go away, and then the $300 million that we're saving in state general funds from the expansion would go away. So you have been well aware of the budget situation, the negotiations that have gone on, and $300 million is not pocket change and would cause significant disruptions in higher education, K through 12, and other areas of our budget. The Senate bill represents a dramatic cut to our program between 2020 to 2026. It would be a $14.2 billion cut to our state, and eliminating Medicaid expansion would be a loss of $12.1 billion in federal funds because of the reduced federal share and our inability to continue the Medicaid expansion, not getting those additional funds. The per capita caps would be a $2.1 billion cut because we are reducing the number of federal funds over time without addressing any of the significant cost drivers of healthcare in our nation. So in sum, the combination of the caps and the reduced federal spending on Medicaid would be about a $14.2 billion cut for our state. These are unprecedented levels of cuts and would cause significant disruptions in our ability to manage the Louisiana budget. Additionally, the coverage for Medicaid expansion is adjusted to the CPI, or Consumer Price Index for medical care, which varies greatly. So within a year, you might get 1% or more flux in that rate, and if you vary the investment to states based on that rate, even a 0.5% difference in the medical inflation would mean a $500 million cut for us. So imagine the difficulty that would bring to our state to manage year to year a program that's providing benefits to folks. What do you tell people in nursing homes or pregnant women or kids? Well, we may or may not have the money for you next year. We'll see, particularly when it's such high amounts of money. A 1% would be a $1 billion cut. So it would be very difficult to manage. The other thing that's uniquely harmful to the state of Louisiana is that it has you take into account 8/4 of Medicaid expansion. We're the only state in the nation that would not have that. We really only effectively have 3/4 that are full enrollment that we'd be able to calculate our overall federal funding for. And so that would make it very difficult for us because we'd have half the amount of money that other states would have for Medicaid expansion. The bill, as I mentioned earlier, does not fix the exchanges, and the poorer you are with the bill, the worse off you are, with costs increasing by as much as 270%. For us in Louisiana, it would drastically increase costs in the private market, and new plans would cover less for more money. So, for example, a married couple at 133% of federal poverty level would, if they got into an accident, need to pay up to 65% of their income for their coverage. And that would take us back to the pre-ACA days where medical bankruptcy was medical costs were the leading cause of bankruptcy. So, we have made significant strides. So as I mentioned earlier, 430,000 people, that was a change from 20% of our folks in the state having no insurance to 12%, and we think that number will go down even more. So I think most importantly, speaking as a physician and a parent, my big concerns would be of the crowd out of the largely adult working population that we've added to Medicaid, and what we'd have to do in terms of rationing of care for folks who are elderly, children and women, and the tough decisions we'd have to make as we have to have people leave the Medicaid program. I find it to be unacceptable. We are the wealthiest nation on this earth, and to me it's an embarrassment that we don't have health care as a right. It should be a fundamental, basic health care, primary and preventive care, and humane care of the individuals living in our country ought to be a foundational belief, particularly when we're a country that is able to pay for it. So this is really the wrong direction. So in your pack, what you should have received, and we're really proud of this, and you can see in more depth our testimonials, is the Medicaid Expansion pamphlet. And in it you'll see quotes from myself and the governor, but also providers throughout the state. And you'll see a little bit of a snapshot of our dashboard, as well as the testimonials. And we have hundreds of testimonials that you can see on our website of individuals who have benefited from care and their stories. As you can see, many of them are working. We have nurses, we have students, we have individuals from many, many walks of life, truck driver, individuals who would have died if not for the Medicaid expansion. And of course, throughout the nation, you can see these stories in the town halls that when the senators do reach out in their communities, you see this nationwide, that people truly believe that this has saved their lives, and we know we can see this through our data. So this is a reference for you. So the other issue that we are not addressing with this bill are some of the fundamental costs of care. And you know that I've been an outspoken advocate for looking at changes to drug pricing. If you look at our Medicare Part D, which is our drug spend, our costs have gone up over 90% over the past few years. Once there is a federal rebate signed for the Medicare program for a drug, we are required to cover it. So I know of no other major industry that doesn't have price negotiation that's fair and transparent, and it results in our state, and some of you may have seen the Washington Post article, it results in rationing of care and individuals who become sick because we are simply unable to afford the cost of the coverage of certain drugs for the population of our state. And the prime example of that is Hepatitis C, where we have about 70,000 individuals in our state. In Louisiana, we have about 35,000 who are either Medicaid or under uninsured. Only 320 of those individuals got drug treatment last year, and that's unacceptable. So we've been working with some of the national policy leaders at Peter Bockett Memorial Sloan Kettering, and his group have created a tool. So if you Google Drug Price Lab Louisiana, you can see the tool, and it allows you to put in the numbers from our budget. And this was created with publicly available data, and you can see to treat X number of people with Hep C. This is off my head, so check these numbers, but approximately 3,000 people we wanted to treat. Let's say 3,500 kids would lose K through 12 education. So it's pretty astounding what the trade-offs are, and I think often drug pricing is presented as that there are no trade-offs, but as a health secretary who has to budget year to year and has to live within a fixed budget, I know that if costs go up in a certain part of my budget, then they have to go down in another. And so that there are ramifications to high prices, and those ramifications in our state are individuals who are suffering and dying for lack of ability to get effective treatment. Another thing that we've spoken, the governor and I, about, which we've found to be unacceptable, is that the U.S. taxpayer has funded the development of the Zika vaccine through BARDA and the NIH, our bioterrorism efforts at the Army. We funded the development of the vaccine as well as paid for the clinical trials that are testing the vaccine, and the U.S. Army is contemplating giving it to a French company, Sanofi, with no protections whatsoever on price. So, for example, if the company wanted to charge, we have about 500,000 people in this state who are of reproductive age who would need that vaccine. If we had local transmission, that could be a $500 million hit to $1 billion hit if you use usual vaccine pricing. So, these are the kinds of things that the U.S. has done or is contemplating and make it very difficult for us to either provide appropriate care or to be able to afford to do what we think is best practice, or what every other industrialized nation in the world is able to provide, because we are the only nation on the globe that does not negotiate to the extent that we do in this nation. Let's see what else, if there was anything. So let me just stop there, and I know you'll have plenty of questions, and take them now. The question is, what are we doing about Hep C drug pricing? So there are a number of options available to address high drug prices. One of them is 1498, which has been used by the federal government, for example, if there is an invention that has significant federal interest or for public health risks. So two examples of that are night vision goggles. The U.S. military was able to use the patent to have that technology save the lives of our individuals in service. Another example would be, and was not employed, but the threat of it when anthrax was a significant threat in the U.S., and a company was not going to provide Cipro, the antibiotic that's used to treat that infection, at a right price. That threat was employed. So that's one option that we have. It is so-called the nuclear option, because it is dealing with innovation and it is dealing with some of the profits, although of course that's one of the things in our armamentarium. So what we've done is put out for public comment, which we have back. It's now on our website, so you can see it. We have asked Josh Sharfstein and the folks at Johns Hopkins to bring together some of the national experts on pricing. So they talked about 1498 as an option, but there are other options. The one that Senator Cassidy and I think is very has great potential is something that we're calling the Netflix pricing methodology. So in other words, you would have a subscription, and the company would get whatever they were otherwise going to get, so they're not going to lose any money. But we'll give them that, and for that period of time, and it would be a limited period of time, we would be able to treat as many people in the state as we could, which would mean lives saved and a much better public health approach. So that's something we're looking at. We're also looking at the National Academy of Medicine recommendations, which suggested that the U.S. could put out for bid to the companies who provide the drugs for hepatitis C, to provide them at a reasonable cost for the low-income and vulnerable populations of the country, and companies would bid on the ability to provide that at a reduced or reasonable price. So there are many options available to us, but my feeling as Secretary of Health is that just letting people continue to suffer and die for lack of treatment, which is the current situation, is not an acceptable status quo, and something needs to be done. But of course, pharma is very powerful and can be a very, very powerful enemy of change, particularly when it relates to profit. So the question is really about the price it would be. So if you look at our budget allocator or the drug pricing lab tool, if we were to treat everyone, which is I believe we should, our goal should be to try to treat everyone in the state. It would cost us $760 million. I mean, where am I going to get that from? you know, K through 12 education, who's going to pay that? So that's the challenge.
Paying now for the interim treatment rather than the cure.
Well, a lot less. A lot less. Right, so that's the problem. So, no, $760 million if we were to take all 35,000 and treat them and cure them. Yeah.
But over the period of years, as the infection worsens, the cost of doctors, hospitalizations, and the other medications, is it cumulatively that greater?
The issue is that, as you know, we are not a couple things. One is we're not a single-payer health system, right? So but countries that are, by the way, are paying a lot less than the companies are asking us to pay, okay? And those countries are able to provide more drug, okay? Because Egypt, it's $1 a pill, and so on. Even in Germany, Switzerland, Britain, much lower costs than what we have to pay. Number two is that we have to budget on an annual basis, right? So we're not the federal government, so we can't borrow money, right? And I have to balance my budget every year. So that's the challenge. So we don't look at health, in my view, in the right way. And I would agree with many of the folks in the field who have been focused on hepatitis C. There are many drugs that are not of value, right? Or they have very marginal value and they're expensive. This is a great drug, and you don't want to inhibit innovation, and you don't want to inhibit the spirit that creates these types of benefits. But then again, why does the company have to make so much money every year? Why can't we have some kind of a balance where you could treat more people and have a public good net? And this has, by the way, been done with the Cherokee people. It's been done with the nation of Australia. I mean, there have been solutions. So I believe that we can take, what I'm working towards is a solution similar to what we did with Medicaid Expansion, where we were told, you have no more tools, you just got to get creative, and we did it. So with Hep C, we're going to have to come up with a more creative, surely there's a way for drug companies to still make money, and a lot of it, but also for us to not have individuals suffer and die needlessly because of the prices being too high. So that's the goal. I don't have an agenda other than that, is to make sure that there's no one in this country that dies or suffers needlessly because of drug prices being too high. And we need to, again, if we were able to budget for 10 or 20 years, and there have been proposals that look at that, what if we could, let's say, mortgage this, right, over a period of 20 years? That's an interesting idea. We can look at that too, although $760 million over 10 years is still a lot of money. So I think we need better solutions, and that's what I hope to achieve with this discussion that we're having. So I don't know, right? So President Trump has said a variety of things about drug pricing. He has said we should negotiate and we get a bad deal. So I don't know where he stands. So without talking to the administration, it's hard to say what they would do. But where we are now is we're looking at the public comment, and we're being reflective and looking at the various options. We're talking to Senator Cassidy. And I think the Washington Post also did, if you got to see it, a very nice follow-up interview with him where he talked about his perspective as a liver doc. And, my hope would be, frankly, that you wouldn't need to employ a nuclear option, and that there would be other options available to us that would allow better outcomes and treatment for the individuals in this nation. But we do need a rational, real discussion about pharma pricing. And so, we're going to be working with Senator Cassidy and other members of Congress on some potential solutions, but at this point we have not decided what we'll be asking for. Well, I think, the good news, so the question is that, there have been a variety of discussions about cuts and the level of cuts and the impact that would have on healthcare services in our state, and how we weather that, and what have been the results of the cuts. So two things. One is that we have been fortunate that the expansion, we were conservative in our estimates around expansion. As you know, we were saying 275,000. We were not thinking, without the additional resources that we thought we needed, and some of the other additional funding that other states had gotten to do Medicaid expansion, we did not want to be overly braggadocious about what we would accomplish or how much money we would save, but we saved more money than we anticipated because we did such a good job, and the unmet need for health care for this state and the number of individuals who wanted to sign up was just so great. That was able to be a lifesaver over the past couple of years. We also have, as a department, learned to look at certain areas. We've done great on the fraud, waste, and abuse. As you can see, we've had some national report cards on being the best in the nation. We're the only state recognized this year as meeting every criteria for excellence in terms of our fraud program. We're looking at pharmacy costs in terms of a common preferred drug list and saving money there. We have reformed and are continuing to work on reforms with our behavioral health programs that affect the individuals of this state. And fortunately, and I think it was a great session, that we were able to get through a budget that, although we have mental health cuts in our budget, we believe that we'll be able to manage them. We don't have to cancel pediatric day health. We don't have to cancel psychosocial rehab for youth. We're going to have to limit some services and get a lot tighter around the services that are provided. But we have, I think democracy is still working in this state, and although sometimes the discussions are not, not everyone agrees on what the right approach is, the legislature gave us a budget that we can live with, that we think is responsible and will not result in major cuts to healthcare services. So that's the silver lining of the past few months. Yes?
All right. So, we actually had Senator Cassidy on Fox News Sunday yesterday, essentially saying that the draft of the healthcare bill, as it is now, federally, is not much going there. Are you pleased with the senator's take on this debate, or do you think he should be doing more at the federal level to be more specific in his plan?
Yeah, I mean, I'm proud to have Senator Cassidy as my senator. He is a practicing doc. He is very aware of the vulnerable people of our state and has been a very constant voice for coverage at the national level. So I couldn't be more pleased. He's been one of the leaders at the national level, constantly bringing up the fact that we need continued coverage for the individuals who have gained coverage through expansion. His plan is a heck of a lot better than the plan that's in front of us now. And of course, as health secretary, I'm very, very glad that the plan is dying, because the plan does not fix, again, it doesn't fix any of the fundamental problems with Obamacare, which really, if you poll Americans, they were upset that the cost of their insurance were going up, right, and that the exchanges weren't working. But this bill doesn't address that. And it takes away the one thing that, as we poll Americans, 62% of the people of this state and the majority of Americans approve of Medicaid expansion. The majority of Republican governors, all of the Republican governors who expanded Medicaid, want to keep the Medicaid expansion. So it's fixing something that's not broken and not fixing what is. So I think it should die, and it's much better to have a discussion about what the real issues are in healthcare, and among those are pharmaceutical pricing, but also the private insurance market and what needs to work. Senator Cassidy has a very good idea, which is auto-enrollment. That would help fix some of the issues with young invincibles not joining. So I would give him an A so far. Right, so I'm not sure I'm prepared to. I can give you just the general overview, which is it's a subscription. So there would be a company. Yeah.
The TV cameras across the state can't hear their questions.
Oh, so the question is, let's talk about the Netflix model for hepatitis C. So the general idea is that, and this would not impact, so part of the problem and reason why drug companies don't want to negotiate is because once they reset their price, then it affects their global pricing, right? So this would be a subscription, not a repricing, so we would subscribe to getting access to the drug, along with the idea would be multi-payer, so you would have Blue Cross, you could have the VA and multiple payer sources, Medicare, right? So we would pool our money and say, what would we normally spend in the state of Louisiana on these drugs in a year? And we'd say, okay, we'll give you that and more, so that we can actually try to get access to everyone in the state who needs it. So that's a general idea, and it's an idea that doesn't threaten the viability of overall pharma pricing. But who would do it, is still in question. So Does that make sense? Yeah. We certainly have tried. I mean, I think that as you saw during the legislative sessions, the Medicaid expansion has never been under attack, and that is because the legislators certainly understand that the Medicaid expansion has benefited the bottom line of this state and has been a huge economic benefit to the state. When we have met with the editorial boards of the major newspapers of the state, we've made public comments, we've put out press releases. I would say, though, that sometimes these messages are complex, and so I don't know if as a former professor of health policy, I'll tell you sometimes even my students didn't understand, that the minute differences between Medicare and Medicaid and health policy is very complex. So I don't know what the public knows, but I know that generally they support the Medicaid expansion, which means to me that they have heard, either know someone, which is probably likely, know someone who's gotten care, they themselves have gotten care, and or they've seen some of our good press about the economic benefit and health benefit to the state. So the question is, are there any other big disallowance threats that we're facing at this current time? There are not. So this was really the elephant in the room. Well, I think it would cause what we call the death spiral is the insurance term for when costs go up in the insurance market. So it would cause the insurance market in the private sector that's non-employer based to have enormous cost increases, up to 270% increases. And of particular importance, the most vulnerable people in that market, people that are older, people in their 50s, people who are sicker, and people who are poor would suffer the worst. So they would lose coverage. The impact would just be incredibly great on hospitals because we would lose our ability to pay. You've seen hospitals that have gone from 85 to 90% decrease in the number of uninsured, and one that I spoke to that had seen no uninsured patients in that month. So all of a sudden you go from that system to people don't have a way to pay for care. Rural hospitals would be at risk. Nursing homes would be at risk. We would have to think about rationing care. If we got 25% less, which some of the, depending on how the bill is implemented, this contemplates, we would have to think about taking 25% of either the services away or the people off of health care, which would impact the ability for us to pay hospitals decent rates. We're already way too low, and our hospital rates are engaging in a very significant reform in that area along with the hospitals. You've heard us talk about the partners in looking at base pay and changing some of our methodologies. This would threaten our efforts to change that. It would threaten our efforts to be able to pay primary care docs and nurse practitioners, primary care practitioners more. So it threatens the viability of the insurance market, but also because it takes $2 billion away from Medicaid payments. That's $2 billion less that our communities, providers, hospitals are getting per year. Well, it's complicated, so it's not a 2-minute answer, but basically in the U.S., which is different from other countries, companies are able to price at whatever the market can bear. So you want to charge $700 for an EpiPen, charge $700 for an EpiPen. You want to charge $90,000 for Hep C treatment, charge $90,000. You want to charge $150,000 for rheumatoid arthritis, go for it. And we don't have the right incentives, and these are companies that are for-profit companies that have investors and shareholders, and so their incentive is maximize profit, right? And unless there is, as is in other countries, an ability to exclude based on price, right? Just to say, well, listen, you want to price your drug at $150,000. We won't pay for it, right? Or you want to come out of the box with that price, we won't pay for it. We don't have that mechanism in the United States, and so we bear the global brunt of pharma prices. Other countries simply do not accept that reality and negotiate. The question is about pharmaceutical negotiation and where the policy levers are from that. So I've spent the last year on a National Academy of Medicine panel, and I had the good fortune of sitting next to Henry Termeer for most of my meetings, who's since passed, who founded Genzyme. An amazing man, and I want Henry Termeer's. Genzyme is a company that manufactured pharmaceuticals for very rare conditions that were deadly, and he saved many thousands of lives. And so you want a Henry Termeer. You want someone who's going to innovate, and you want keep that. And so, you know, he and I debated, and as did the other members of my committee who were tasked to tell the public and to give some recommendations to the Congress on what to do. So I'm not sure that Congress is not willing to do it. I think we are reaching a national tipping point where if you survey the public and policymakers, they do, particularly when you see the price gouging of some of these companies, where you've seen it with buying generics and then drastically increasing prices, or the EpiPen and drastically increasing prices. And I think that the public are getting tired of this, and that it is time for a rational discussion about how to continue the innovation and the genzymes and the life-saving innovations of this country, how to continue to support the NIH and the research enterprise, but also how do we get more fair shake for the Americans who need drugs and for states who have to pay for them. Yeah, to change it, you would need federal action.
Does it apply to all parts of the industry of the United States, like the VA, Medicare?
So, no, VA, so the question is, does it apply to everyone? No. So, for example, the VA can negotiate better prices, and in California, the legislature did try to pass a bill to say that Medicaid would pay no more than the VA, and pharma put over $100 million into fighting that bill. The question is really there are other cost drivers. Pharma is one of them, and I don't want to just single them out. I'm not, uniquely interested in the pharma pricing. The cost of care in this country is out of control in many areas. When we build expensive technologies without thinking about the ramifications, as we do in this country, when we provide, as has been documented in research, up to 40% of the procedures or treatments we do are either not followed or not valuable or not recommended. So we have a huge amount of problems. There's also some numbers that by 2040 or so, over 60% of every American's income will go to health care, and by the time I need Medicare, it won't be around, right? So these are real issues, and we can't keep putting our heads in the sand and not addressing them, but we should not do it on the backs of the working poor who need health coverage, because every other nation on this earth has figured out how to provide a basic level of care for their citizens. So what frustrates me about the national policy discussion is that we're not looking at the triple aim, which is how do we get healthcare costs down, how do we improve the patient experience of care and reduce the overall cost of care. Instead of having the real discussion we need to have, we're talking about cutting poor folks off of Medicaid. And it's the wrong discussion, and we deserve in this country to have a real discussion about healthcare costs. So single payer is a solution, but there are other solutions, because many countries, so for example, Germany has a insurance program that is you buy in as part of your work and you stay in it through your life. You have some countries that have a basic level of care, and then you buy in additional if you want silver, gold, or platinum care. So there are a lot of ways that we could provide insurance to individuals. You have the British model, which we could employ, where you look at overall for publicly funded programs, for Medicare and Medicaid, for example, you would look at the evidence base for certain procedures or medications, and you would decide based on evidence, would you cover them, would you not, if there was not sufficient evidence to cover certain things. So there are many ways to address healthcare costs. We could negotiate pharmaceutical prices in a fair way. We could recognize the investments that Americans make in terms of the research enterprise, our NIH funding and so on, when we look at drug prices. There are lots of things we could do, but right now, in terms of the current bill, those are not being entertained. It's an interesting question. I mean, employer-based, a lot of countries post-World War II created their National Health Service while they were rebuilding from the war. Of course, America did not have that type of war on our soil during those years, and so we built a very different model that's based on employer coverage. Employer-based coverage is not I would argue, is not the problem in this country right now. Employer-based, most people are satisfied who have care through their employer. The issue is individuals who don't have a large employer, are self-employed, are partially employed, or unable to be employed. Those individuals really fall through the cracks. I don't know. The U.S. we're a free-spirited, competitive bunch, and I don't think that a single-payer system is going to happen in this country. And so we have to think about how do we use the best of what we have, which, in my belief, employer-based insurance is one of the tools that we can use. but build on it so that that's not the only option, so that Medicare and employer-sponsored insurance are not the only option. So, Senator Cassidy, I think, is much more nuanced in his ability to vocalize his concerns with the American healthcare system, and is more thoughtful about those.
Was he correct about the shortage?
He's correct in some ways about shortages. You in this booklet can see how many people got primary care, about 1 in 4 of those individuals. So in the areas where I think it's most important that people got care, which is primary and preventive, no, we are not seeing the shortages. No, doctors, yes, doctors did take the patients that had Medicaid, but yes, we continue to have problems with orthopedists and adult hematology and some of the specialties where the pay is just not as good. But it's certainly, as you'll see through our testimonials, been a life changer for those individuals. Senator Kennedy's staff, one of the last calls I got, the staffer didn't know the difference between Medicare and Medicaid, left on my answering machine. He wanted to talk to me about Medicare. So I just think the level of, and I would say Senator Cassidy's staff is very interested in working with us, wanted to hear about the numbers, spent hours working with our staff, making sure they understood the implications. Not a single outreach from Senator Kennedy to really find out what the impact of this would have been on our state, which I think is a failure.